Welcome to another CME podcast from NEI, the Neuroscience Education Institute. In today's CME episode, Dr. Andrew Cutler will be interviewing Dr. Roger McIntyre about the most current findings on the mental health impact of the COVID-19 pandemic. For complete CME information, please refer to this podcast description page or go to nei.global/podcast. Let's listen in as Drs. Cutler and McIntyre discuss the mental health consequences of the COVID-19 pandemic.
Welcome to another NEI podcast. I'm Dr. Andrew Cutler, your host, and with us today is my good friend Roger McIntyre. Roger, it's great to talk to you again.
Andy, always great to chat with you, especially about this topic today.
You're not kidding. This is so topical. What we're talking about today is the mental health consequences of the COVID-19 pandemic. And really, that could be looked at from a variety of points of views. But why don't we just start out, Roger? What impact has the media's response had, do you think, on the psychological well-being of people during this pandemic?
Well, for me, Andy, I think the media, at least too much of it, has contributed to one of the triple threats of this. I call it the triple threat of anxiety, insecurity of finance, and quarantine. Those are three hazards to brain health and to our quality of life. And we did a study in China, which is now in press, where we looked at media consumption. Andy, when you and I talk, portion control, at least I've always thought that meant food and booze. Mm-hmm. But portion control is not just food and alcohol, it's social media and news media. We found that in China, a survey of just under 3,000 people that we looked at, we found that the more social media and news media that they consumed, that is more than 3 to 5 hours a day, which is not that hard to do nowadays, they were more likely to report clinical levels of depression, anxiety, and even PTSD-related symptoms. So again, I don't think it's about blaming the media. I think, and I should also mention that people who had portion control on media, they did not see that hazard of media. So I think it's about having accurate, reliable sources of media and keeping it within portion control. That's kind of what we found in our survey.
That is fascinating. It really is. Another aspect of this is that so many people, as you mentioned, are facing financial stress and they're losing their jobs. The many businesses are at risk for being shut down. What are these psychological consequences of this?
Well, Andy, you're right. And I think that, when I first started hearing the projection of unemployment, and of course, you had this incredible shutdown of both the supply and the demand side of the economy, which basically means everything shut down. I started, frankly, reacting to this in a way I was thinking, wow, this is unheard of. And one of the most replicated, if not the most replicated population health finding is the link between unemployment and suicide. Again, that's an association, not causation. Mm-hmm. And one can go back to the Great Recession, the Asian financial crisis, the Great Depression. And remember in residency, we all learned about Durkheim, the great sociologist, and suicide.
Yes.
And French sociologist, the father of sociology, he was one of the ones that talked about how being integrated into a community can protect you. And obviously being unemployed is not just being unemployed, it means you're no longer integrated into a community. And this contributes not only to loneliness when you're no longer part of a community, but the hazards economic are significant. For example, I call it the 1% rule. During the Great Recession, for every 1% increase in unemployment in America, in Canada, in Europe, there was a commensurate 1% increase in suicide. Wow. So look at what we're looking at, Andy, in terms of some of the unemployment rate right now, close to 13, 14%. I know it's a number that changes a lot. So I think it really is a clarion call for us to really not just flatten curves, but to get ahead of the curve of suicide and mental illness linked to suicide.
Well, this is fascinating because, I hadn't thought of what you just said. I'm thinking about the financial stress, but you're absolutely right. A lot of people have their friends at work, so they're losing their friends and their connectedness, their social connectedness, and social media doesn't replace that human interaction.
Absolutely. And, the 19th Surgeon General of the United States was Dr. Vivek Murthy. He was with the Obama administration. And I thought his prescience on this was amazing. He flagged the loneliness epidemic as a major public health problem in the United States. And he specifically called out the workplace, the so-called gig economy, the virtualization, working from home. He said that clearly helps some people. But for a lot of people, not being at work is also a loss of their only social connectedness that they have. And he saw that as contributing to loneliness, which itself is linked to not just depression, but also linked to obesity and premature mortality. And I think we're hearing more and more about this. And that's why I call it the triple threat, because you have the anxiety of the virus, both getting it and passing it on. And then you have this economic assault. And then you have this sort of quarantine and physical distancing, which, this has been a combustible mix.
Well, it's interesting you talk about the physical health effects. I think we all clearly, intuitively understand about mental health, stress, anxiety. But you're talking about physical health too, which I hadn't considered. And I'm thinking for myself, for instance, my gym was closed for several weeks. Yep. And the impact that had, I wasn't exercising as much. People are at home eating more, and they're eating more junk, for instance. So it's really
absolutely. And just think what exercise does. We know exercise is the ultimate poly pill. It does everything we want. Beyond the sort of preachy and sort of very basic things we know it does, it obviously is good for your sleep. It's good for other aspects of health. But this is actually interesting, Andy, because this is about resiliency. And there's a lot of interest in what resiliency is. I think we kind of all know what it is, but it's a little hard to operationalize it. But exercise, among other things, provides not just a physical and biological, but also a cognitive emotional resiliency. I have to say, this survival through this whole situation of COVID-19 is about resiliency, social resiliency, individual resiliency. And I see exercise as the great augmentation of resiliency. And among everything else it does, it's wonderful for us.
Well, I can tell you the other thing a gym does. I've got my gym buddy, so we have a little social club there. So, there's also social interactions.
Absolutely. Yeah, absolutely.
All right. Now, what about social distancing? Okay. So obviously there's quarantine, but let's say even if you do go out, my wife and I went out to dinner the other night and we're sitting 6 feet away from other tables and we're wearing masks and things like that. What effect does social distancing have on our psychological well-being?
Well, it's interesting, Andy. I was sort of thinking about this a lot the last 2-3 months. From an evolutionary perspective, as a species, one of the reasons that we're social organisms is to protect us from threat. That's one of the reasons why we became social creatures, is it reduced our threat. It increased the likelihood of passing our DNA on to the next generation. And what's peculiar, this is a time of unthinkable stress at the individual and societal level, and we're being told to stay away from people. In fact, it's worse. We don't even know if the person sitting at the other table actually has this virus. So it's a peculiar, perverted set of dynamics that we're dealing with that I think is kind of going against the grain of evolution, because we tend to gravitate towards each other during times of stress.
It's fear of the other. You're absolutely right. That gets magnified.
It's magnified, and we tend to gravitate towards people as a resiliency enhancer. And it's interesting, Andy, because, Toronto was the city that was most affected outside of Asia during the SARS epidemic in 2003.
Yes.
And I remember we were quarantined back then, and I, as a healthcare worker I remember these days, and people did some studies on this, the effect of quarantine. Now, again, going back to SARS, there wasn't the economic shock. The virus itself was fairly well contained, relatively speaking, to what we're looking at now. And so investigators, and this was published in a paper in Lancet, a systematic review of this, looked at what is the hazards of social distancing and just being quarantined. Those are related but different. And they found bad news. We're not wired for this. People have more anxiety, more insomnia, more PTSD, and resorting to binge drinking during these times. That's why I call this the triple threat. And many of us have the luxury of having access to media. We can reach out to friends and so on. But a lot of people don't have Wi-Fi or broadband. They don't have a big social network. And so this is not just being told to stay home. It's severing all their social contact.
That's absolutely true. Well, let's talk a little bit about some of the disruptions in people's lives here. What are the psychological implications of some life events being canceled or maybe being done virtually now? Weddings, graduations, proms, award ceremonies. How does this affect people?
Well, it's interesting. I remember some of the great work that was done in terms of some of these early studies out of Harvard where they tracked this cohort of men for many decades. And then there was a study out of Rochester, New York, and some of these following these cohorts of people, empirically really affirming what early psychodynamic therapists talked about what's the long-term effect of missing or having pathogenic life experiences. We as human beings are a narrative. And when you have a piece of the narrative that's taken out, or maybe it's been negatively influenced by trauma or what have you, it creates dissonance within the person because we're a narrative. And I can only imagine that, people getting married and wonderful things like that in life, but also people who've lost people and they couldn't even go to the bedside with their loved one or even attend funerals in some parts of the world.
Right.
I mean, it's just difficult to get your head around. And we're hearing more about virtualization of all of this thing. And I think the next 18 to 24 months will be very revealing as to what impact this really has had on people, especially as some of the, let's cross our fingers and hope that this thing's in the rearview mirror by then. I think it will be, but we'll see. But I think it's going to have effects on the existential notion of who we are and how we identify, and we're a narrative.
So I'm thinking about the effect that this has on family structures and routines, and particularly the impact on domestic violence and child abuse. Can you talk a little bit about some of the disrupted family structure and what effects this could have?
Yeah, I mean, this is something which I think is really, really important. And there's been a fairly significant history on intimate partner violence and its amplification, especially during times like this, where there's been unemployment, forced congregation and isolation. And, when we look at, for example, violence and alcohol and drug use, especially amongst middle-aged men, unemployment is especially hazardous to middle-aged men. When you look at the literature on unemployment and suicide, both women and men are affected. But there seems to be a pattern that emerges that men especially are affected more than women, and we can maybe conjecture why that is. And I think that there's a narcissistic injury, there's a narcissistic
and
shock.
Define themselves as through their work. That's the right
Absolutely. Absolutely. And there's a sense of failure and shame, and often that, along with other factors like the lack of portion control on alcohol, creates a very dangerous and kind of almost like a regressogenic environment where it regresses and people resort to very maladaptive ways of coping. So I think we are hearing about increases in intimate partner violence, and that's obviously something of significant concern.
Absolutely. Yeah, and I'm just thinking about also to answer your question of why is this different from middle-aged men. Women tend to have more social networks. They have more.
That's right.
They communicate better emotionally and things like that than men.
Absolutely.
I'm thinking too, when we're thinking about the family structure being altered, I mean, I'm thinking about people now working from home. Personally, I've never done so many Zoom meetings in my life. Homeschooling is another aspect. I've got 2 teenage boys who finished the school year virtually.
Yep.
Having the family quarantined in isolation, there are days where you're just looking at each other going, what are we going to do today?
Yeah. Yeah, absolutely. And, one's not surprised when you hear the results from different surveys. There was a survey just completed by Oxfam, half a dozen countries, just published June of 2020. And they found that women were much, much more likely to report clinical levels of distress, anxiety, insomnia, as were women of minority and women of less economic advantage. And one translation of that is that when women are working from home, they're taking on additional responsibilities. And often people of minority and people who don't have economic advantage don't have the opportunity to have, home help and things like that. So I'm not surprised when I'm hearing that they're reporting higher levels of distress and higher levels of anxiety. And this coincides, Andy, as you know, the University of Chicago in June just published their social survey, the National Opinion Research Survey. This is the one that reported that only 14% of Americans even feel happy or very happy. But they're also reporting very, very high levels, 50 to 60% depression and anxiety. And when you get into the weeds of it, you find that a lot of these surveys are finding women more affected than men. And I think in part it's because of some of these additional responsibilities I think women are taking on.
Well, another issue, of course, when we think about who are the people who have the essential jobs and have to go out of the house and have to be exposed, it tends to be women, and it tends to be more minority women, more in service jobs and things like that.
Absolutely.
Heard a lot about that lately, too.
Yeah, absolutely.
All right. Well, we've talked a little bit about the rate of substance abuse and alcohol abuse, and it's fascinating to me that liquor stores here, I don't know about Canada, but they're considered essential, and they've been open through the whole time here.
Yeah, in Canada, they're essential as well, despite the fact that alcohol is a well-known immunosuppressant. And despite some of the marketing of alcohol, it's certainly not known to be an elixir for mental illness. It clearly is not good for brain health when consumed in excess. We've also heard, Andy, as you know, an increase in cannabis. Across Canada, we in Canada are just like the United States with respect to having an opioid epidemic. The opioid epidemic is a North American phenomenon. It's confined to North America, Canada, and the United States, which itself is interesting.
That is interesting.
Yeah, you don't see it outside of North America. And we've now seen an increase in some of our provinces in opioid deaths occurring over and above the already shocking high level that it was and that it is. So we are beginning to see some of this happening. And again, I think that's the distress. You probably know, Andy, that Express Scripts, which is a pharmacy benefits manager, they reported about a 35% increase in prescriptions for anxiety medication and a 20% increase in prescription antidepressants. So you're seeing this portent, you're seeing this kind of rumbling clouds coming in about the storm, whether it's the behavior, the maladaptive behavior of too much alcohol and binge drinking. And you have now an increase from an epidemiologic perspective of pharmacologic agents for well-known conditions linked to stress.
And who do you think is most vulnerable here? Is it people who have pre-existing mental health issues? Is it people who haven't really previously had much issues? Is it both? What do you think's going on?
I think it's both, Andy. We've been hearing so much about COVID-19, who's most at risk of the infection, who's most at risk of complications. We've, of course, heard a lot about the elderly, especially nursing homes. We've heard a lot about, for example, African-American and Latino background being more at risk. And I think when we take that same level of granularity and we apply it to the mental health side, we find something revealing. Yes, this is a tremendous distress for everybody. But the reality is that people who have pre-existing mental illness, people who are less economically advantaged, you could also say frontline workers are also especially at risk. We did a study in China as well, another one, Andy, where we compared the general population to people who already have depression, already have a diagnosis. And this won't surprise anybody, I don't think, but those with pre-existing mental illness reported much, much greater levels of distressing anxiety and depression, insomnia, and PTSD. But the general population levels were already high too, so this is quite a statistic. And what's interesting, Andy, just kind of on the conjecture side, we've spoken about this at NEI and over the years about how mental illness itself is linked to immune dysregulation. And so you could almost conjecture that in part because of social factors like crowding and insufficient access to healthcare, perhaps also aspects around illness literacy, but for other reasons like biological reasons, having too much obesity, too much alcohol consumption, and as well having immune dysregulation, many of our patients may be at greater risk of contracting COVID and having complications.
Yeah, it certainly makes sense, I'll tell you. I'm just thinking also about, these increased prescriptions for antidepressants, anti-anxiety medicines. I'm wondering if some of it might not also be higher compliance on people who have been prescribed these medicines. Maybe they're more likely to take them now.
It's a really interesting question, and it'll be interesting to see. I think what would be an interesting pursuit academically here, which I think would be interesting to clinicians broadly, is we should find subpopulations in our society who are doing really, really well, who are actually thriving. We're hearing about people thriving during this time. And that's interesting. And it'd be kind of interesting to almost deconstruct what is it about these folks, what's the resiliency, other than some of the social resiliencies, what's about them personality-wise? How do they cope like this? And maybe those are as instructive to us as learning about vulnerability. And some people are telling me that some people find they're thriving better during this time. And I think to myself, wow, that's perplexing to me. But some people seem to thrive. And if it's true, I would like to see more evidence of that. I'm hearing this anecdotally. But if that's true, we have as much to learn about resiliency as we do vulnerability.
Certainly. Well, I'll tell you anecdotally, my wife, who's one of the most mentally healthy people I know, has taken up painting and is teaching herself Spanish and is very happy. So,
nice.
That strikes me as doing those kind of things, learning new skills, trying new things. Maybe there's hobbies or things that you've always wanted to do. This might be an opportunity for that.
Yeah, and I think, Andy, to that point, I think you're probably going to see a rethink of sorts. I think this is certainly taking people off the treadmill, that's for sure, so to speak, with respect to their fast-paced life and running off to this meeting and that meeting. And there's a bit of a rethink. And, it's interesting because we've never had better economic times prior to COVID-19. And yet ratings of happiness in society could never be lower. And, satisfaction in people's lives could never be lower. And we have a 30% rise in suicide the last 15 years. So there's a disconnect. There is a disconnect. And I think that this may encourage a bit of a rethink.
Yeah. Well, we know that the social divide keeps growing over the past 30 years. The haves have more and the have-nots have less. So
right.
That certainly contributes. Hey, let's shift gears here. I want to talk a little bit about telepsychiatry, which, surveys have shown that very few of us were using telemedicine before this, but now virtually everybody is. How do you think telepsychiatry can help reach this growing need we're talking about for mental health treatment?
Well, Andy, it's amazing. I heard a statistic 2 weeks ago that Zoom had 10 million subscribers in January. Now they're at 300 million.
Oh, my goodness.
Yeah. This came from the actual company itself. So I would say, well, congratulations to those who have shares. That's one comment. But I think the more germane part to our conversation is, I think telehealth, what's happened in 3 months eclipsed what's happened in 3 decades combined in terms of us adopting this technology. And to be just point blank to your question, I think that this has really provided an opportunity for the access question, because we have problems with access, with quality, and with coordination. And telehealth provides cost-effective access opportunity and also an opportunity for quality with respect to a virtual medical home possibility. We're hearing more about that. I used a lot of telehealth before this happened, but not this much, of course. And I think that it truly has been well received, importantly, by our patients and families. That's something relevant as well. So I think it's been overall a good thing. Of course, there were questions, Andy, as you know, around, safety and how to handle psychiatric emergencies and obviously privacy and confidentiality aspects and reimbursement. A lot of these HIPAA aspects came into play. And I think that there's been a scrambled way to deal with all that. But I think it's been very positive overall.
Yeah. Now, obviously, there are certain things, we weren't trained to do telemedicine, although maybe some trainees now, people in med school and residency now are getting this. But certainly you and I really never had any training on this. And it seems to me there are definitely some things that are needed, some skills. You need to have some basic familiarity with technology. You obviously have to have access to devices that can do this, cameras and such. And then high-speed internet is critical. You need relevant skills. You're going to need things like explaining to the patient what you're doing and why, explaining to the patient, for instance, that when you're not looking at the camera, maybe you're looking down to take notes. It's not because you're not listening to the patient. You might have to have the patient move in closer to the camera, move back away farther from the camera to examine more of them. You need to make sure that you're in an area with few distractions or not a lot of disturbances.
Right.
So there's all kinds of techniques to this. And then you mentioned the billing aspects are fascinating as well. Insurance companies vary with respect to billing and the coding, Medicare, Medicaid rules, things like that.
Absolutely. Yeah, absolutely. And not to be light about it, but you also need to be very cautious as to what room you as the clinician are sitting in and what's in the background and so on.
So true.
We've heard a lot of embarrassing things that have taken place.
Oh, yeah.
But for me, I think the biggest challenge I have, I've been using telehealth, again, like everybody else, full time. And for me, it's getting used to this new ecosystem, not the teletechnology, but for example, trying to assure I'm speaking to the patient in a confidential way. Often people live in small homes and their families all in the same area.
Yes.
So these things we haven't typically thought of. But what I have found, Andy, just as a kind of comment, is that I have found that my interviews actually becoming shorter in duration for some reason. I thought, am I missing something? But there's almost like an efficiency that was happening, I thought. And I talked to colleagues about it, and they were finding a similar experience. I thought, am I sort of shortchanging the patient? I mean, these interviews are going faster. But I think there's an inherent structure. I mean, you're in obviously a little picture on your computer. And for some patients, not all, but for some patients, it actually might be a preferred way to keep things contained, especially for some patients who, for example, let's say patients who've had a trauma history. And for them to come to a live meeting, especially if it's opposite sex and things like that, that could be very activating and very unpleasant for them. And we work with people on that in a very empathic way, but for some people it can be very distressing for them. And perhaps there's a safety for some people afforded by this telehealth as well, Well,
I'm sure you're right. And so this points to something we've noticed recently, and that is our no-show rates have dropped dramatically because People are showing up now because they're at home. All they have to do is click the link. So we have very few no-show rates. And I think some of it was what you're saying. Some people just were too stressed and decided not to come. It was too painful or stressful to come into the office. Yeah, so clearly the other thing you said, which I think is true, is that we're discovering for some patients in some situations this might be almost preferable. And I think moving forward, we're going to be in a hybrid world. We're going to have a real blend. I don't think we're going to go back to just like pure office practice anymore.
Oh, I agree. That horse is out of the barn for sure. And I think that's right, the hybrid model for sure. I have to say, I still like seeing patients in person. I think many of our colleagues do. But I think this is an efficiency. In fact, I had used the telehealth before. My office is in downtown Toronto, which is a little bit like downtown New York or LA. The traffic is terrible. It's expensive for parking. And, when I prescribe a medication, we like to see a patient back in the clinic, say, in 2 weeks, just to kind of see how things are going. And for the most part, things are usually going okay. But that costs the patient 4 hours, time off work, parking, this and that. And patients really like those types of opportunities to use telehealth for that. Admittedly, we figured out ways how to handle psychiatric emergencies. I mean, I see people with depression and bipolar only. And of course, suicide is very much a part of these situations. And, we have to issue a certificate of involuntary admission sometimes for patients.
Yes.
And that requires a bit of thought as to how that works in this virtual world.
Do you get patients permission, for instance, that, look, if you are to get into an emergency, I reserve the right to do something about it?
That's right. And for the most part, I've had this happen quite a few times. I've asked patients to come to the emergency room, and of course, they have a lot of fears about that. We deal with that, and they come. The way the legislation works in Ontario, which I'm sure is the same for many states, is that if I have sufficient concern and the patient refuses to come to the emergency room, I can issue a form, and then law enforcement will pick the patient and bring them. And these are the kind of things that we probably didn't think through as much before this all started. I've used telehealth for a long, long time, but admittedly, I didn't have many of these emergencies that I've had. In the last 3 months, I see lots of people who are very suicidal. So this has come up quite a few times the last 3 months.
I see. Well, we just talked about the emergency room and the healthcare environment. Let's shift gears to thinking about how has the pandemic affected the mental health of the frontline healthcare workers?
Well, this was something that we saw as SARS in Toronto with the mental health of frontline workers. And you can sort of think that obviously they're citizens of society. So there's these general reasons why we're all in this together. So they actually are at risk. But think about this. People are working extremely long hours, often working off service. I mean, I got an email from our hospital asking if I wanted to work in the ICU. I thought, oh my gosh, that's not a good idea. And so, people are working in many cases off service. PPE, I mean, we're wearing those PPE masks and all. That's not very comfortable for hours and hours and hours. And then, in fact, you're being told you shouldn't go home to your families at night. You should probably rent a hotel or get a B&B or something like that, or Airbnb, this type of thing. And so I think, look, this has been a real assault to people's mental health. And then people have been telling, a lot of my colleagues were saying that they kind of felt a bit stigmatized because once they announced that they worked on the front line, then people were like, treating them like they had some, contagious disease and so on, right? And we heard these tragedies that started in Europe, some of the frontline workers, not just nurses, but physicians and other staff committing suicide. Of course, that's not cause and effect, but that's, I'll call that's co-localization that makes us very uncomfortable. And we heard some cases in the U.S. that this has happened as well, and also here in Canada.
The emergency room doctor in New York City who committed suicide.
Yeah, absolutely.
Part of what was cited was, at least in New York City, which got the brunt of it early on, but it's now spreading across the United States, and I can imagine this is going to happen elsewhere. There became shortages of equipment, of PPE, of potentially of ventilators. People are having to make these horrible life and death choices. They're watching patients die at a rate they haven't seen before. They're watching people die alone because the family's not allowed in to visit them. I mean, I can just imagine the stress.
Oh, yeah. Unbelievable.
There's a concept, too. There's a concept here of something called moral injury that apparently is very common as well in this setting. And this is distress from actions or lack of actions that violate somebody's personal moral or ethical code. And then it can cause negative self-thoughts and feelings of guilt. And apparently this is something that's not that easy to treat. I can imagine that psychotherapy and counseling is critical, but it's not easy to treat. It strikes to someone's core.
No, absolutely. It strikes to someone's core, and it strikes to the very mission as a care provider, and being forced to make these types of decisions, which are gut-wrenching, unthinkable. As you said, it's a great moniker, moral injury. It really is injurious to the essence of who people are.
Well, let's shift gears and talk a little bit about some healthy coping strategies. What are some healthy coping strategies maybe that people can adopt or that parents can model at home for their children during this pandemic?
Well, you spoke about what your wife is doing, and I think that really resonates, Andy. I think that Freud was asked, what's health? He said, to work, to love, and to play. And, and play meant to pursue hedonistic, arts and things you like to do. And, his wisdom carries on. And I think that when we bring this to more empirical dissection today, never underestimate how important structure is. And I think we all lived a structured life before COVID-19. You're up at a certain hour each day, everyone's life's routine. But structure is, yes, it feels very basic, 101 approach to health, but it is critical. And then to get good sleep. And of course, we talked about portion control, not just on alcohol and food, but the media, but also, again, remaining connected. And again, this requires respecting the public health officials' recommendations, but using technology-assisted connectivity, of course. And, many people don't have a very large social radius, but that's okay. There's other things, religious institutions or, affiliation like that, community centers. One of the more powerful ways has been shown to reduce stress and to improve your own immune system is to do things altruistic for other people. And that's kind of a socio-biological kind of effect. And it's an interesting finding. And so I think that's certainly critical. What's interesting, Andy, is that Sheryl Sandberg, famous Facebook person, she was very public about the loss of her husband a number of years ago. Mm-hmm. And she wrote a book recently on resiliency. And I thought it was a very well-written book, quite frankly. And she talked about people who are resilient and they have this ability, really kind of the P's. They don't personalize it to them. They don't make the event pervasive across their entire life, and they don't make it a permanent event. They seem to be able to recognize this is not permanent. This is a finite event. It'll come to an end, and I'm not going to let it pervade my whole life, and it's not going to be personalized to me. And those 3 Ps I thought was a very nice kind of little cheat sheet, little mnemonic, and it kind of captures the essence of people who seem to be quite resilient.
Well, and speaking of altruism, you just reminded me of Katie Couric, the famous broadcaster in America. Her husband died of colon cancer, and she started a foundation for colon cancer research, I believe. It strikes me as extremely altruistic and a very healthy way of coping with such a loss.
Absolutely.
Speaking of unhealthy ways of coping, there's one area that we need to touch the bases on, and that's patients who require medication-assisted treatment for opioid use disorders. We talked a little bit about opioid disorders earlier. So those who need MAT, I'm thinking about how would this treatment change? Because these are people typically who come into, say, a methadone or a substance abuse clinic regularly and get their medications and things. So it seems to me that this is going to change too. Do you have thoughts on that?
Yeah, I mean, it is. And first of all, it's an effective component of opioid use disorder. And I think that a bit of pragmatism is probably going to be the guiding light here with respect to shifting more to parenteral administration. And obviously some, additional prescription for takeaway is going to be required. It's just the nature of just being pragmatic. Not ideal in many cases, but not a bad actually solution in other cases.
No, I think you're right. And I think that's an example of how we have to think about. Another example is I see a lot of patients with ADHD. Prescribing stimulant medications are a little more challenging in this time. And of course, in the US anyway, the DEA has actually loosened up on the restriction. The previous restriction was you had to see a patient in person in order to prescribe stimulants and controlled substances. And now they've loosened that up and are allowing telemedicine.
Right, so absolutely. Which is great.
The models are changing. And then I do a lot of clinical research and things like patients coming in to get their next week's batch of medication. How do you handle that in this environment? So we do things like touchless. We'll set it down on a table and the patient will come over to the table and pick it up and this kind of thing. Or I've got an appointment with my own personal physician coming up and I got a letter saying you're going to wait in your car instead of sitting in our waiting room, until we call them in. So
okay, that's interesting.
Yeah. All right. Well, this has been really terrific. I just want to ask, sort of as we wrap up, what other resources might be available to help people protect their mental health during this time?
Well, I think that we've covered a number of bases. I think people need to be aware of the fact that mental health services are still open and people should reach out where they need the help. I'm a director at DBSA, Depression and Bipolar Support Alliance, and
yes,
DBSA has a fabulous website that has many different videos and material, which people find very helpful and supportive. And look, the peer support groups are still taking place across the U.S., virtually, of course. Mm-hmm. And one of our colleagues, Dr. John Cameron, just north of New York, you may know John, he actually has a group, and I've been encouraging him to write up some of his data because I think this has been an interesting, not just support for people, but I think it's been a very psychiatric first aid for many people during this time. So peer support still exists, and I think that people should really consider, go to the DBSA website.
Yeah, it's dbsalliance.org. I've gone several times. I've gone frequently, and I recommend it all the time. Also, the National Alliance for the Mentally Ill, the NAMI, is another organization that's very helpful and especially can help family members of people with severe mental illnesses. So there are a lot of resources, a lot of respectable organizations. The National Institute of Mental Health actually has a very informative website as well. And I think overall, finding healthy ways to maintain social connections, finding new structure, new routines, getting into those newer, healthier routines, paying attention to portion control, exercise, sleep, all of those things that we've talked about, I think hopefully will help people get through this. But I'm not Svengali here, but if I had to predict, I'd say we're going to be in this situation for quite a while. I
think you're right, Andy. And I think that the viral aspects, they will come to an end at some point, although not soon enough. Yeah. And I think we really need to pay close attention to aspects of the economy and our patients' social circumstance, because we learned during the quarantine in Toronto after SARS that a lot of the PTSD and mental health related problems declared themselves a little later, like 6, 12, 18, 24 months later. So I think that you're right. I do think this is going to go longer than we had expected, but I think it's also this sort of echo pandemic of mental illness is one we got to pay very, very close attention to. Well, I think life as we know it will be changed forever. From now on, it's going to be pre-COVID-19 and post-COVID-19, almost like pre-9/11 and post-9/11. Mm-hmm. So we're going to be in a new world. I agree. World, if you will. Yeah, I agree. Right. Roger, as always, it's just been wonderful talking with you. Fascinating, and I really appreciate your time and your knowledge. Oh, always fun, Andy. Great to connect, especially on this important topic. I agree. And so I want to thank you, the audience, as well, for listening, and I hope you found this to be helpful and informative. And for more information and access to more of our podcasts, you can go to the NEI's website, which is www.neiglobal.com. All right, thanks so much.
Thank you for your participation in this NEI CME podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to go online and print your certificate. This concludes the CME podcast presentation.